My name is Dr. Phuong Nguyen. I'm a gastroenterologist and therapeutic endoscopist at Mission Hospital. My office is based out of Newport Beach. And tonight we would like to talk to you about a very common entity, gastroesophageal reflux disease, otherwise known as GERD or acid reflux. Thank you for your attention.
And hi, I am Dr. Samar Kanaan, thoracic surgeon. I am primary office is centrally located in Irvine. My office number is 949-679-6874. And I do robotic hiatal hernia and CTIF in conjunction with Dr. Nguyen for patients with large hiatal hernias and gastroesophageal reflux disease. And my portion of the talk will review just some basics of surgical history, approach, anatomy, and then a short video discussion of the steps and conduct of the operation, and then answer any questions. Thank you.
A common story nowadays, I see the millennial population go out, they drink, and at the bottom of the shoe there's a little pocket, and so when they open that little pocket, it contains a anti-acid medication called the Proton pump inhibitor, and so the younger generation is popping these anti-acid medications like candy as they eat and go out. So why do we care about GERD? It is it increases risk for esophageal cancer. So when we look at the different types of cancers in terms of frequency, in the middle column here, and you see the graph looking at between the year of 1975 to the year 2000, you see a rising incidence of esophageal cancer, and that risk, although not fully understood, it's thought to be related to GERD or related to gastroesophageal reflux disease. And what happened is, as acid reflux from the stomach back up into the esophagus, you have increased incidence of this entity called Barrett's esophagus, which is precancer. And the severity, the duration of the reflux symptoms is positively associated with increasing risk of esophageal cancer. So you see here, this black line of esophageal cancer, it really trumps everything else like lung cancer, melanoma, and along with the incidence of esophageal cancer, of course, goes mortality, which is increasing death associated because it's a very deadly and very aggressive type of cancer. That's what you see on the right. So that's why we care. That's why we care about GERD. This is the Barrett's esophagus, which is precancer. What happens over the number of years of acid reflux, acid from your stomach coming back up into the esophagus and causing irritation. So this is normal esophageal lining here, that where my pointer is, and this is that change in the inside lining, and this is called Barrett's esophagus, and this is thought to be precancer. So after continued acid reflux, what will happen is it goes into cancer, and here you see this mass and narrowing of the esophagus, and it's pretty ugly. What is GERD? So GERD is an abnormal, frequent chronic reflux of acid from the stomach into the esophagus. Some patients think, some people actually think it's an overproduction of acid in your stomach, and that's not the case. It's actually just a normal production of acid in your stomach, but something happened at the bottom of the esophagus that allows the stomach acid to reflux back into the esophagus and cause issues and irritation and Barrett's and cancer. Okay, so the typical symptoms of GERD include heartburn, chest pain, regurgitation. Patients can have bloating in the epigastric area. So these are some more typical symptoms of GERD. Atypical symptoms of GERD include cough, sore throat. Some patients describe excessive clearing of the throat, and they don't notice it, but they go through their day and they keep trying to clear something that's at the back of their throat. Dental erosions, bad odor, gum disease, ear and jaw and nose discomfort. And then there's this whole entity also that it can affect the lungs. So patients with asthma and COPD and interstitial lung disease can have a component of GERD that is causing the difficulty. So again, GERD, same thing, synonymous with acid reflux, and that occurs when the stomach contents, stomach acid, backs up or reflux into the esophagus. Okay, so definition of GERD. What causes GERD? What is the anatomic problem that occurs? So, well, normally when you eat, the food goes into your esophagus, and then it goes into your stomach, and then small intestine, and colon out the bottom. Okay, so the esophagus is a tubular structure that joins your mouth and the back of the mouth with the stomach. Okay, so at the bottom of the esophagus, there's normally a sphincter, and that sphincter will open, and food goes in after you swallow, and it closes back up. Okay, so here you see normally there's the diaphragm. So the diaphragm is what separates your chest and your abdomen. And when you breathe, the diaphragm flattens and then it domes up. Okay, so the stomach should be below the diaphragm in your abdomen, and the esophagus should normally be above the level of the diaphragm. Okay, what happens in GERD is the stomach actually slides up above the level of the diaphragm into the chest, and that's called a hiatal hernia. Okay, so that reduces the function of this whole area. So that's one anatomic reason why we have GERD. Other reasons or other pathology behind GERD is the lower esophageal sphincter intermittently can open, it can be weak, it can be shortened. There are other ligaments that kind of hold the structure in place, and some of those get broken over time. There's this deterioration or loss of elasticity in this area. So those are some of the anatomical failure that occurs that causes GERD. So we think now the understanding is GERD has two sphincters. So the number one sphincter we talked about is this green structure, and that's the diaphragm. And that holds, the stomach, keep the stomach in the abdomen, keeps the esophagus where it is. And the second sphincter that we understand that has to do with GERD is this thing in blue, which is the lower esophageal sphincter muscle. Okay. GERD, when you talk about symptom and treatment, is a spectrum disease. So you can have milder disease or you can have severe GERD. And the intervention depends on the severity of the condition. So milder disease would be, that millennial I explained, have episodic GERD symptoms. They pop a medication now and then, but then they're fine. As we progress into the spectrum of disease, you can have progress to the point where you need chronic anti-acid medication to feel better, control the heartburn symptoms. And later on in the spectrum of disease would be esophagitis and Barrett's esophagus we talked about, and of course, cancer development. So the more severe the condition, the more intervention that we do. So the disease or the symptom drives how aggressive we are in treating the condition. When you look at how common this entity is, it affects 1 in 4 people in the United States. And many patients suffer and the symptoms aren't controlled, but whatever they try, whether lifestyle changes, medications, they still have symptoms. But all those who have symptoms, very few undergo surgery or intervention, because traditional conventional surgery used to be thought to be too aggressive and have complications associated with it. So now we have endoscopic therapy and less invasive therapy that can intervene and improve GERD with less complication rates and less side effects. So we talked about the medications to suppress the acid. So you're taking an anti-acid medication to cut the acid from the stomach, so when it regurgitates into the esophagus, it doesn't cause the burning. So when you take the anti-acid medication, most of this is over the counter. The simple antacids are like Tums, Maalox, Mylanta. The next level up, the more potent anti-acid medication is the H2 blocker. And in that category, there's Pepcid, Tagamet, and Zantac was just recently pulled off the shelf by the FDA due to its side effects. So that being taken off, a lot of patients are now saying, wow, my God, what else is going to be taken off? And I have no choice but to take the next level up, the more potent proton pump inhibitor. And here you have things over the counter like Protonix, Privoseg, Prevacid. And again, all these medications are to suppress acid. It does not suppress regurgitation. So what you're doing is you're cutting the acid, but stomach contents can still come up into the esophagus and it can still be troublesome. So there are many published associated risk with long-term PPI use. So using this proton pump inhibitor, we used to think that it's, very little side effects and people can use it long-term and have no problem. But studies have been out looking at everything from dementia down to nutrient deficiencies. The two most believable, I think, of all this are increased risk of osteoporosis and kidney disease associated with chronic PPI use. There was also a study that just came out from Los Angeles and looking at patients on chronic PPI with increased risk of COVID infection. And a large series from just a week ago showed that patients with chronic PPI use have increased risk of colon cancer. So PPI is really not without risk, something to consider. When a patient comes in with GERD, what kind of things are we looking at and how do we diagnose the condition? So initially, if patients have had chronic GERD, they're symptom controlled. As the years go by, the condition worsens and their symptoms worsen. And when there's a change in symptom, we worry about ferrets and we worry about cancer. So an endoscopy where we look at the inside lining of the esophagus to look for complications of GERD is usually the initial testing that we do. And it looks, for esophagitis, any stricturing, ulceration, Barrett's. And this endoscopy typically takes about 5-10 minutes. You are asleep. And here we can also evaluate the lower esophageal sphincter. We'll look for a hiatal hernia. So it's an initial, very basic evaluation for GERD. At this time of endoscopy, we can also place a little capsule, and that's called Bravo for pH testing. And we attach the little capsule on the inside lining of the esophagus, and we have the patient wear a monitor for 4 days. And what that does is it looks for acid in the esophagus over that time. So we look at severity of the condition. We can correlate with the symptoms the patient's having. For example, if they're having cough, we can see if the cough is associated with a reflux event. So we can correlate disease with symptom. We can look at upright or supine reflux. Are they refluxing when they're standing or where they're sleeping? And of course, the severity of disease. To the left here, you see a manometry study. So this is looking at the function or the motility of the esophagus. So whatever we do in the future to fix this anatomical problem at the lower part of the esophagus, we want to make sure the top of the esophagus is functional so that no food will get stuck. So this is a basic, very simple test that we do to assess the motility or the function of the esophagus. Sometimes we obtain an esophagogram, which is a swallow of contrast and taking pictures of the esophagus to look to see are there any strictures or any mass? So it looks at it's an anatomic assessment of the esophagus. So this is what a Bravo study looks like. It's a pH study. This is actually a 2-day study. Here you see the line and it draws the pH of 4. So anything below that line represents a reflux event. So the patient has many reflux events. There are some that come up to the line but doesn't actually drop below the line. This is the nighttime period and daytime. So this patient had a lot of daytime reflux and no nighttime reflux. This study is consistent with GERD and again, mostly upright reflux. And there's 100% symptom correlation with heartburn. So whenever the patient said, I have heartburn, it correlates with a reflux event. Very similar when they had chest pain. So this is a ambulatory pH test to diagnose GERD. So earlier on, I talked about the spectrum of disease. So the intervention, earlier on in milder conditions, we talked to the patient about lifestyle changes, eating smaller meals, don't eat so late before you go to bed, avoid things that make GERD worse, like tomatoes and wine and caffeine and, pretty much everything that's good in life can increase GERD symptoms. Sometimes I will, jokingly tell the patient, well, you can't eat anything that's good in life because it'll worsen the GERD. Maybe you can drink water. And oftentimes the patient will respond to me, well, with water, I reflux too. I have regurgitation. So even with water, you can have regurgitation. So lifestyle modification, it's okay for some, probably earlier on in the disease spectrum. When patients then take anti-acid medication, they take it for years and, gradually it doesn't work anymore. They require more medication. And that happens because the mechanical failure at the bottom of the esophagus has gotten worse. The situation doesn't get better over the years. It just gets worse. So patients usually notice that, the medication either don't work, they need more, and they have breakthrough symptoms, even though the medication had worked before. So then we talk about intervention. What can we do as a physician to fix this anatomical problem at the bottom of the esophagus? So now we have an endoscopic technique called TIF. So TIF is transoral, incisionless fundoplication. So endoscopically, we can put in this device and we can create a valve at the bottom of the esophagus. And this device is called a TIF device. And inside we can put a scope, and this has a light so it can show us what we're doing at the junction between the esophagus and the stomach. Okay, so this draws the diaphragm. This is introduced through the mouth. The patient is sedated, and we work to build the valve that decreases GERD or acid reflux. What we do or accomplish is the full thickness tissue fold at the G junction. As we pull this mucosa, the lining, into the device, there are fasteners that are placed. They're like sutures to create a valve. Okay, so after all this is done, what you'll see is a 3-centimeter flat valve, and it's a 270-degree wrap. So the traditional technique, maybe some of us have heard about, called the Nissin Fundoplication, is what we've done for many years. That is a complete wrap of the stomach around the bottom of the esophagus. And that sometimes can be associated with difficulty swallowing because it's just so good at preventing reflux that patients can have difficulty swallowing, difficulty burping, and they can have some bloating. Okay, so this TIF valve accomplished just enough, just that balance between just enough to prevent reflux, but it's not too tight that you don't have any problem swallowing. So complications are low. And many clinical studies have over the years shown that TIF is effective. And this has been around for greater than 10 years. So initially we had compared TIF to sham. We looked at multi-center randomized trials that have shown it to be effective. We have 5-year data, we have 10-year data. So the TIF evidence, many systematic reviews, randomized trials, over 140 publications with many thousands of patients with long-term follow-up showed that TIF is effective. So how is it effective? It looks at quality of life improvement. So here's your baseline. And at 1 year, 3 year, and 5 years, when your symptoms improve, it actually lasts. Looking at quality of life, elimination of regurgitation at 1 year, 2 year, and 3 years, up to 5-year follow-up. Looking at elimination of atypical symptoms, here again, you see the similar numbers that is effective. So that's how the patient feels after TIF. How does the patient do with objective measures? So the objective measures are, does the patient get off their anti-acid medication? Does the TIF procedure improve esophagitis? And over many studies, it performs very well in getting patients off PPI. So if you look at this number, I don't think this number it's good, but I don't think it's so fair, because what the studies look at is whether you're on or off. So it doesn't actually look at patients who require less medication. So if you include everybody who went off medication, required less medication, this percentage, I believe, will be higher. Percentage of patients with improved esophagitis, again, performance is pretty good. Here is looking at pH score. So that's that Bravo study that we talked about, measuring acid reflux with the pH study. So here it also showed that some of the patients can have normalization of the pH score and study. Effectiveness of TIF is summarized, improves heartburn, regurgitation, quality of life. pH studies improved and normalized, depends on the study, there's a range. Decreased need for PPI at 5 years, again, there's a range of patients who stop PPI completely. I think TIF is, of course, superior to PPI in eliminating and reducing what I talked about before, which is regurgitation. Because again, the PPI shuts the acid, but it doesn't prevent regurgitation. Many meta-analysis, looking at thousands of patients, many studies, procedure success with very few side effects and significant improvement in GERD. Again, I'm gonna skip over this. Durability, this is immediately what it looks like. This is the scope. This is an image of the stomach. You see some fresh blood because it's during the procedure, immediately after the creation of the valve. So again, it's a 3-centimeter TIF valve with that 270-degree wrap. This is looking from the stomach. Again, this is the scope. 1 year post, the valve looks similar. So TIF indication is for patients with a 2 centimeter hiatal hernia or less. So if the hiatal hernia is 2 centimeters or more, that is, if too much of the stomach is up into the chest above the level of the diaphragm, then we recommend a hiatal hernia repair as well as TIF, and that's called a C-TIF. So this is a study looking at a concomitant hiatal hernia repair and TIF. So the studies show that this is also effective in controlling patient heartburn and symptoms with no long-term dysphagia or problem swallowing and no bloating. Again, adverse events, very minor symptoms post-TIF. When you look at large series of patients, very few adverse events that are major. TIF indications we talked about briefly, GERD symptoms despite PPI, patients who are on chronic PPI want to get off PPI, patients with Barrett's esophagus who want intervention and don't want to use long-term PPI, abnormal pH testing, hiatal hernia that's small, unless we repair the hernia and TIF. Very few contraindications, patients with strictures, patients with limited neck mobility, and of course, prior esophageal resection. I think I've gone over my time. I'm going to introduce Dr. Kanaan. Dr. Kanaan is actually the premier, the best thoracic surgeon that we have probably in Orange County and definitely at Mission Hospital. And I'm so proud to be working with him in the past few years. And our results and our outcomes have been phenomenal. And I think we can't do any of it without Dr. Kanaan. And he's so kind and so great with patients. Thank you for speaking to us tonight.
Thank you. Can everyone hear me okay?
Yes, Dr. Kanaan.
Okay, great. Dr. Nguyen, I echo the sentiment. I think Mission Hospital in Orange County is very blessed to have a very talented physician. I learned a few things from your talk that I hadn't learned before. So really fantastic, and thank you. And it's really been a blessing to work with you. You know, I'm not going to give any background that hasn't really been excellently done by Dr. Nguyen. So no disclaimer. So you know, as surgeons, we always pay you know, homage to our history and our predecessors and our mentors. And so, yes, Dr. Nissin was the first surgeon who really operated on someone who had reflux, esophagitis, and ulcers. And his strategy was to wrap the top part of the stomach around the bottom part of the esophagus to prevent the acid from coming upwards. And so this worked. He published his series, and it was known as the Nissin Fundoplication and has been known that way ever since. Of course, he did his open, and we've evolved to doing it laparoscopically, and now we do it robotically, or I'm one of the surgeons who does it robotically. But as Dr. Nguyen correctly pointed out, this 360-degree wrap caused a lot of problems, not being able to belch, not being able to having bloating and some really unwanted post-op effects. And so again, his focus was really on the wrap of the stomach, while others like Dr. Allison in England thought that maybe more of it was fixing the hernia, so putting the stomach back down into the abdomen and having the correct you know, pressure, because the abdomen versus the chest are different pressures, and so that way it would help people. And of course, now you can do the combination. And the wraps over the years have many different names. And like Dr. Nguyen had said, being able to do the fundoplication from the inside, the TIF approach, really is an excellent outcome for patients. And if you have a large hiatal hernia, now you're able to do both parts. So doing this robotically to fix the hiatal hernia, put the stomach back down in the abdomen where it belongs, closing the hernia part so it's not so loose, and then having the third component is the TIF component of taking care of the incisionless fundoplication. And so the combination is gone very well. So I'm going to show you the video. Again, I do this robotically. The advantages of the robot is you can zoom in 10 times. It's three-dimensional. It's a full articulation of instruments. Can everyone see the video playing? I hope so. So you can see in the left there, picking up the stomach. That's what the stomach looks like. And that yellow tissue there is the fat. And this device I'm going to use is, we call it the Synchro device, and all this technology is at Mission. And basically, just dividing that fatty tissue to free up the stomach. In the distance, you have the spleen. On the top there, you have the liver that I've retracted out of the way. And so, you know, pulling the stomach down and bringing it back into the abdomen is one of the important aspects. Here I'm dividing what we call the short gastric vessels. And now I'm moving up to the left crus or muscle of the diaphragm. And the idea is that I want to get the entire stomach down into the abdomen, out of the chest. Furthermore, this mobilization will make things easier for Dr. Nguyen when she has to do her fundoplication from the inside. So some of these blood vessels and scar tissue have been freed up. Again, the advantage and the wonderful teamwork we have is we have the latest technology at Mission with the XI robot. You can see how beautiful this picture is. Some people always ask me if I'm playing a video game, and yes, you know, in a sense, you are really just zooming in and manipulating the tissue. And now I'm going to move over to the other side of the diaphragm. I've kind of clipped this video to be, you know, less than 10 minutes. So if you bear with me, we'll get to all the aspects. But as you can see here, I'm freeing up the stomach and esophagus. Now I've moved to the other side, and you can see that this is the other, the other side of the esophagus and the muscle. So you see the muscle to the right and the esophagus to the left, and I just kind of move the tissue. I've reduced the hernia now, and I'm just freeing up the esophagus so it can sit comfortably and happily in the abdomen. And this is on the patient's left side. I know it's the right side of the screen, but you know, we're looking at the patient, if that makes sense. And so I will dissect now the other side of the esophagus. So this is the right side of the diaphragm. And you can kind of get the sense that tubular structure is the esophagus. And I'm going to free up all this tissue and basically reduce the hernia. One of the analogies I use with patients is that you can imagine that the stomach is like stuck on puppeteer strings stuck up into the chest. And so if I don't divide all those puppet strings, then the stomach will just sneak right back up into the chest after surgery. So I have to divide all those strings or those adhesions or scar tissues so that once they're all divided and the stomach is pulled down into the abdomen, it stays in the abdomen and it won't you know, have a recurrence or another hernia again. And you can see with this dissection, I've moved to the other side now. I've gotten all the way around the esophagus. What I love about the robot is, you know, it's very little trauma to the tissue, no blood loss. Here I'm going to bring for my assistant a little plastic, we call it a Penrose after Dr. Penrose, but the idea is that this will allow me to gently tug on the esophagus in an atraumatic way so that my assistant can pull it for me and then I can continue. So now I've reduced the hernia. Stomach is in the abdomen the way I want. The muscles are dissected, and now I'm going to start to suture the hernia closed. So part one is done. We've reduced the hernia and the stomach into the abdomen, and now I'm going to take some suture and basically just sew this by hand. Typically, I'll use anywhere from 2 to 4 sutures to reapproximate the muscle back together. Once the hiatal hernia has been repaired and the stomach has been placed in the abdomen, then I will exit, and then Dr. Nguyen would do her portion of the fundoplication from the mouth on the inside. As a note, this is very, important structure. So again, the liver is above me. Obviously, you can see that beating. That's the heart above the liver. Underneath this muscle that I'm grabbing with my suture is the aorta. So, this is very delicate, very fine suturing, and, you have to see everything to be safe and make sure that you have an excellent result. And again, the robot really does allow that. So, when I'm sitting there using my hands, it does exactly what my hands are doing, meaning that I turn my wrist and the needle turns, and it really does mimic everything that you're doing. We have a couple more minutes, and basically what I do is I tie, and I, take more suture, and I didn't want to bore you with my tying aspect there, but you can see there's one suture, and then I'll lift and I'll go ahead and place a second suture and a third suture. So you can see that that hiatal hernia will be closed and will be nice and snug, so that the hernia can't happen again, and the esophagus and stomach will stay in the abdomen. I know we're going to probably get to some questions here, and I'm going to see if I can perhaps fast forward just a little bit so everyone understands. But you can see how the instruments will mimic my wrist as I tie, and this essentially takes care of the hernia. One of the beauties of this operation is, I usually keep the patients one night in the hospital just to watch them, make sure they're not nauseous, and they go home the next morning. They really have, skin glue. There's no sutures to remove. I want them walking immediately. I want them obviously with a restricted, kind of liquid diet initially for all the swelling. We don't want them to get nauseous. But patients really have little to no pain. As a matter of fact, I saw a patient recently in the office who, is back to work, literally within a week of this surgery, and really has had no pain. I'm just going to fast forward so that basically we'll get to the end portion here. And you can see once we're done, it's nice and snug. The esophagus is happy, the stomach is in its place, and I'll just remove all the instruments. And that really is the operation. We can see that we'll remove our drain and remove our catheters, and let's see if I can get to the next slide here. And I don't know. Okay, so again, the advantage of our robot is you can see things, less trauma, less pain, less complications, shorter hospital stay, people get back to work. And I've operated on patients in their 80s or older who really do well with this kind of operation. I will certainly open it up to any questions, and maybe I'll stop sharing my screen so that Chelsea can take back over here and see how I can do that. There we go.
Thank you, Dr. Kanaan.
All right, so I really am excited. I think that this is the TIF, and of course, if you have a large hiatal hernia, the C-TIF. We have a great team. We have a great endoscopist and leader in Dr. Nguyen, and I'm glad to be part of this great team at Mission, and thank you.
A wonderful evening again. Thank you so much for taking the time to join us this evening. Thank you, Dr. Kanaan. Thank you, Dr. Nguyen.
Good night, everyone.
Bye. Thank you.